So we're going to jump right into the first panel. As Jeff noted, we have two esteemed physician leaders who are here with us. Wayne Jenkins, the CMO at Centivo, and Greg Brusco, the Chief Clinical Officer at Ascension. And this is really intended to be a relatively open conversation around a really critical topic, which is the whole issue of the primary care patient relationship and what value and opportunity sits with those. Just by way of introduction, I'm Dave Oechtendorf. I'm the Chief Actuary at Centivo. I've also had the good fortune over the years in my consulting world to work with the BHCG as their strategic advisor. So I've been very close to this process all the way through. And you know, it's always dangerous to give an actuary a microphone and have him be the MC. So we'll see how that goes. But I'm going to start with a couple questions, and then I will urge anybody in the office, in the audience who wants to ask a question to come up to the mic, and we'll see if there's anything that comes in via email as well. But Wayne, I'll start with a very straightforward one for you. Ashok spent a fair amount of time talking about the primary care relationship and how it really does, if it is done correctly, improve health, and how it really does create a better patient experience. And that all sounds good in theory. What does it take to make it real?
So let me go back, Dave, in that question and sort of go back a few years. And I know Greg had done some of this same work at Lehigh Valley, and I'm going to go back to Orlando. When we were at Orlando, the head of Disney Benefits called and said, "Why is your total cost of care 18% less than your competitor?" And I said, "It's really our primary care model." And so I'm going to talk about, when we talk about primary care relationships, we'll talk about, you know, there's that individual relationship between the doctor, patient, clinician relationship that's key. But it's often about a team. It's a team, you know, so when we refer to it, we're going to often talk about it, team-based care. And so when we were doing that in Orlando, probably like they were doing at Lehigh Valley, we were looking at, as you remember, healthcare reform, the accountable care organizations, you know, Medicare changing, you know, payment. And it was really set up so that for those elderly patients that had high cost, could we get them with a team, with that primary care physician, but also the team surrounding them, whether it was behavioral health, care management, all that important team. So I think that one of the key aspects is always, as we know, access, but it's really early on getting someone connected to that team. Like we say, we don't want their first visit to be into the emergency room, and connecting them with that team. So that, to me, was fundamental to how we did it and what we're looking for when we're looking for partners to do it.
Thanks. You know, Greg, that's going to raise a question. And for those of you who are looking at the slide relative to the network configurations, one of the names you saw in all three network configurations was Ascension. And so, you know, Ascension will be a key player for us in this solution. And we're talking about, you know, really connecting people to a high-performing primary care physician. How are you going to make sure we have enough primary care capacity?
Well, Dave, I think we just hire 1,500 more. I mean, isn't that what everybody does? Probably not a strategy that we want to go with. Not terribly effective, but all kidding aside, there's a couple of avenues and strategies that we can implement that we've been working on. One is, and as we talk about this, it's going to sound like, don't you do this every day? This is like basic blocking and tackling. But that is making sure that our current existing primary care workforce is optimized to the extent that it can be. That can be practice operations. That can be EMR consolidation as it relates to communication, making sure that they're appropriately staffed. Please don't think that those things are taken for granted, because as health systems expand and you expand your primary care workforce, you have to sometimes deliberately pay attention to that everyday blocking and tackling to make sure that you maintain standardization from an access perspective. The second component is utilizing mid-levels, right? So PAs, nurse practitioners can be incredibly helpful and are a tremendous asset in the primary care, even in some specialty cares, but certainly in the primary care workforce to allow access as it relates to employers and employees. The third, which got an awful lot of press through COVID, is the virtual platform. And I'm going to make one comment about virtual platform as well as the urgent care model, which is sort of a fourth area that I want to be very clear about. every block now, it feels like, to some extent, has an urgent care popping up. Some are part of health systems, integrated in health systems. Some are third parties, fourth parties, fifth parties, national chains. From an employer perspective, while they do provide a venue for access for your employees to provide basic primary care in some instances, I think the critical component of this is making sure that they are integrated with the health system and the primary care physician or clinician that's taking care of your employees, because it will allow for seamless integration and communication if one of your employees is seen at 11 o'clock at night on a Sunday to their primary care physician on Monday morning to make sure that they understand that their patient was seen the night before. So the integration of those telemedicine and I know they're different, but as it relates to the primary care relationship, the integrated component of that is critical. So that basically 4 different avenues really to provide access from that perspective to expand our current workforce.
Great, thanks. Wayne, I'm going to come back to you. One of the things that Ashok spends some time talking about and is a key element of the program is that this is PCP-guided care. We're really asking patients as one of their key responsibilities to work with their PCP in terms of starting the care there, and to the extent they need referrals downstream, working with the PCP to actually create that referral process and to get to the right place of service. There are going to be some people out there saying, hey, haven't we tried this before? Didn't we have strong referral management and that horrible word, PCP gatekeepers in the past? And didn't we all think that was horrible? So what's different? What's going to make it work?
So I think, let me just take the word gatekeeper to begin with. Of course, that I was, as I said in the introduction, a radiation oncologist in the 90s. And the idea that a PCP doctor was the, quote, gatekeeper, really almost trying to deny someone care, not only was that bad for the patient, it was bad for the doctors. I mean, like to say, okay, now my role is to sort of keep someone from getting something. So I think that was just fundamentally flawed. If we look at the model now, it's not a gatekeeper, it's how does that primary care physician, nurse practitioner team facilitate getting the referral to the right place. And in the models we have, there's no approval process. If your PCP refers you, that's the approval. And so it's really, and then it's also like, how do we look at the data? How do we look at, who really functions as a cohesive member of that medical neighborhood? And it's really all about facilitating that integrated care and the optimal care, but really moving away from that idea of gatekeeper, which I think was fundamentally flawed in multiple ways.
Greg, I'm going to ask you a hard one, because there is a meaningful change going on in this model as we talk about the PCP approach. You all heard from Ashok that one of the first steps you go through in this high-performance model is activating with a primary care physician, and that we are doing some segmentation in the primary care physician community and looking to activate with the higher-performing primary care physicians. That always creates some level of disruption, and it's a hard decision for a member who's had a relationship that may have to change. So we know sort of the reaction from the member side. Let's flip it around. What is the reaction from the physician side as we go into that process, and how do we address it?
Look, no one wants to be the outlier, right? So we know when we go through a stratification process from a quality and cost perspective, there are always going to be outliers, and physicians as a whole generally, for all the wrong reasons, do not want to be outliers. So we're not naive to the impact that this is going to have as it relates to the change management component of our clinical workforce. Having said that, the only way that we're going to sort of crack this egg is to crack the egg. At some point, we're going to have to take the proverbial leap and assume the challenges associated with trying to manage through the clinical workforce and their perception of being sort of called out for whatever reason. And so the transparency of the data is going to need to be shared. It's going to be critically important that we're open and transparent with this. And ultimately, I think what happens generally in that scenario is it usually rises for the outliers, their level of care in terms of quality and cost, because the premise being that no one really wants to be an outlier. So we're not naive to the challenges that that's going to clearly provide for us, but we're willing to take that risk and move on, push through that. We're going to have to. Otherwise, we're going to be having the same conversation 5 years from now.
Dave, I'll just add to that. I think, in my opinion, the physicians just want clarity. Like, sometimes, and many times if you say, oh, you're not performing well, you want to know why, and you want to know how do I improve. And I'll give you a couple of examples in another market where we are. I brought to one of their medical directors, here we have some data that this gastroenterologist isn't performing well, and this cardiologist isn't performing well. And they were key members of that medical staff. So when we sit down and look at it, it was actually correct. That gastroenterologist was repeat scoping too much, and that's a corrective action on their part. On the cardiologist, turns out this person was running their most high-risk congestive heart failure clinic, and so there was some reason for overutilization, and we said, okay, so we're good. But I think if you have data, if you have a plan that people can act upon, then they act upon it. But so I think that's part of the key point.
Transparent data.
Yes.
We have to provide it to them.
Yes.
Thanks. And I guess I will, just having been part of the process here, add one real point of emphasis from the business community. The steering committee has told us very directly that our goal should be to have 100% of the primary care physicians in this community be high performing. Our intent is not all, for years and years to have a group that gets cut off the bottom. And so I think that has been one of the important initiatives and something that we've really shared with the health systems. Greg, I'm going to come back to you with a question that has been important to us from the Centivo side and important to the business community. And it really comes back to the whole partnership idea. What can we do to help your PCPs and all of your physicians perform better in those roles? What can we give you? What aren't you getting today that we can change?
Well, Dave, I appreciate that. That's kind of a softball. One is accurate patient attribution. We struggle with being able to know who we're being accountable for taking care of. That seems so basic, but yet many of you in this room know that accurate patient attribution, particularly in the primary care space, has to be foundational. Once they understand and know who it is they're being held responsible for, then the next phase of that is going to be timely data, timely claims data. So they know how they're performing. Generally today, 90 days, sometimes 120 days, they're always playing catch up in terms of whether it be screening measures, whether it be A1Cs, whatever the quality component is that they're being held responsible for. The general theme is at least 90-day-old data that they're trying to chase. Completely unrealistic expectation from a performance outcome if you're constantly behind the ball as it relates to your data. So attribution number one, timely, accurate data, as real time as humanly possible. There'll be some lag, but it can't be 2, 3, 4 months. That's an unrealistic expectation. So those would be the two big asks. If we can accomplish those things in that order, then I think that's a huge, huge step forward for us.
So Dave, I'd also add to this one. So when I was in Orlando and we did this, we completely redesigned a lot of our care delivery model, and we changed what we call the hospitalist model. If you come in the emergency room, we changed it so that everybody didn't get admitted. People, we had stricter criteria, and we actually canceled 90 contracts and moved to an employed model. So we put tremendous effort to change this value-based model. Disney recognized that, but we were sort of left with, well, other employers didn't have the sophistication of Disney, and that's sort of where these kind of roles like for a Centivo come in. But I think it's really important for the business community to understand that systems that put a lot of effort into changing this value-based design, like you're doing at Ascension, if it's not funded, it's just going to die on the vine. So I think that it's really important to understand, you know, the business community being a payer for this really needs to foster this, or otherwise those people that are out on the leading edge are sort of just left out there, you know, without the funding sources to drive that change. So I think that's a key point too.
Just an additional comment, because I think Wayne touched on a very strong point, and that is, obviously, Ascension, not only in Wisconsin, is pretty large, but nationally it's gigantic. So we have tremendous support organizationally to drive some of the change that you're talking about, and that's a critically important point, is you need to have organizational support. You know, none of us are going to do this individually. We don't have the bandwidth to do that, but with organizational support, which we are very fortunate, both locally and system-wide, to have, I do definitely think we can implement some change, for sure.
Great. Wayne, I'm going to give you a question that, you know, I get back when I talk to sort of the regular, ordinary people, and I'm talking to family and friends, and they're silly enough to ask me what I'm doing these days, and I start waxing poetic about healthcare. And we talk about the primary care role, and they get to the question of, well, you know, when I'm diagnosed with cancer, I want to see the Waynes. I want to see the radiation oncologist. What good does my PCP do? They can't treat my cancer. And so how in this model does the PCP actually provide value when I've got a significant acute situation?
Well, so that's a good one for me, since I used to live in that world. So Wayne wasn't going to manage all of your medical problems that you had going along with that. So that's the easiest part of it. But you need that trusted place that you go back to, one, because you may have a cancer problem, but you may have a heart problem associated with it, and it gets complicated. And so you need that place to turn. Or do I go for a second opinion? Where should I go? So I think the sicker you get, actually, the more important that role becomes. And it's been a terrible frustration on the primary care part, that they feel like someone gets a significant illness and, oh, now they go to the cardiologist, or now they go to the oncologist, but there's multiple issues still occurring that aren't being addressed, and people are often left adrift. So I would flip that to say, actually, that's when it becomes more important than less important, when things are going pretty well.
Just a brief comment on that. It's very rare, so I'm a general surgeon, so it's very rare that whether you're a radiation oncologist, a surgeon, or any other interventionalist of any type, that whatever you're treating, maybe as an outlier acute care, doesn't have some spillover effect on some associated comorbidity that a patient may have, whether it be diabetes, high blood pressure, heart disease, whatever it may be. So to Wayne's point around the importance of having primary care lockstep with those specialists, not just shove the patient off to the specialist and somehow they're going to manage this in their own little tiny silo, is an unrealistic expectation. Primary care has to be at the table associated with integrating that patient's care because of the effects of whatever we might do on their comorbidities. That's just how it works. Very rarely do we do something that we can ignore their diabetes, ignore their hypertension, doesn't really matter what happens. That's probably not how we want to manage it. So.
Let me see if there are any questions from the audience for these two esteemed docs. You got a chance to talk to two of the premier physicians in the community, frankly, in the country. So, are there any questions that want to be raised from the audience? Go ahead. Why don't you come on up to the mic and.
How do you see social detriments to health play into this new model, and how do you see that being addressed?
I'll take the first stab at it. Social determinants of health, obviously everybody in the audience and online are very well aware of the impact that it has on managing particularly chronic care. There's no debate about that. I think one of the challenges that we have, number one, is identifying from a community perspective who is the highest risk, right? So in a health plan, if you have open and transparent data, that might be a little bit easier. We can't even get complete and accurate patient attribution today. So I think in the BHCG, Centivo relationship, in terms of sharing data, The primary step has to be able to understand and identify who at the population level and community level is the highest risk. And then you have to, in some way, risk stratify what those risks are, because it's incredibly resource dependent, right? Everybody understands that very well. So that's sort of a work in progress, I'll describe it that way, moving forward as it relates to the population health space, which a lot of health systems are investing a lot of money in these days, trying just to understand, let alone manage.
So I'll give an additional answer to that, and once again, I'll refer to other places we're looking at in the country so one of the things we're talking about, team-based care, and we went into a community, and I and some of the people I work with started looking at, okay, what kind of primary care teams might take care of somebody? So there might be the traditional person, we talk about panel size, that, a physician had 4,000 patients, like, come in, what's your problem? You're next. But then when you look at a team, and maybe there's a care manager, there's a health coach, part of their job and role is to understand the social factors that someone undergoes. And until you really sort of know all of those things, and there's people addressing it, it probably is not going to be the physician who does it, but it may be another team member. So I think that sort of ties into that team-based care. And another thing is, we talk about wellness visits. And we'll start this, when someone is this up front, okay, that's your patient. You elect them, it's not after the fact. We saw this in North Carolina. They got everybody in for these, we called them wellness visits. It's up front, like, get to know us. We don't want your first place to be the ER. What social determinants do you have? And sort of do that from the outset. So that would be my comment.
And at the risk of piling on, I will add one more thing. I think one of the things that Centivo did when we put together the PCP activation process is made sure we thought about some of those things. So when we talk about selecting a primary care physician, we ask for some very basic, facts. What language do you like to speak? How do you like to be communicated with? Is it text? Is it email? And we ask for contact information so we can actually talk to people. That's one of those things that is so simple and yet so missed in healthcare, and really creates an opportunity.
Thank you.
Go ahead.
The question is for Ascension. Obviously, you're competing or want to compete under this arrangement for more PCP customers. You want to hold on to those that you have already among this population. So you want your PCPs to come across like Marcus Welby, who will do all things, very friendly, supportive staff. But on the other hand, you got to deliver results that are cost-oriented. And so my question for you, I guess, is that as a network, how you hold your PCPs more accountable under this arrangement than they might already be, if there's any difference at all. And when I say held accountable, I mean, what sorts of internal data do you get from your encounters of people coming to see a PCP, and how are you holding those PCP experiences or physicians or nurse practitioners accountable so that you can maybe apply supplemental rewards or penalties under this arrangement, not what you're doing standard today?
Yeah, so we try not to be punitive about it. So there's not so much a penalty component. I think I'll focus more on what we do from a positive outcome. So number one.
But is it different what you're describing now, or are you going to do something, from what you've been doing today, globally, no matter who the payer is, versus under this arrangement? Are you doing something different for those PCPs under this, that you're compelled to do under this arrangement? Or is it going to be standard practice? Not that your standard practice is bad or wanting. I'm just trying to differentiate whether the overlay of this arrangement, how it impacts the PCP performance, that they're held to account individually.
Yeah, I don't think it changes our expectation of them as it relates to providing high-quality care at the lowest cost they possibly can. I do think what this arrangement will provide us, however, is some of the things that I mentioned earlier that allow us to identify if we do have outliers, and that is accurate attribution and timely access to claims data, so that we can be as proactive as possible in managing patient outcomes. That's a huge gap. that this relationship is going to provide us in a much better scenario. But as it relates to fundamental expectations of our primary care doctors, that doesn't change. We want them to be as cost-effective as possible, but at the same time, high quality. And obviously, from a quality standard standpoint, we have, like every health system does, I'm sure, have quality standards that we expect them to meet as it relates to A1C, hypertension, screening, et cetera, et cetera.
But when you're saying looking for other claims data, that's because your PCP may make a referral to see an orthopedic physician. And if that patient goes out of your system, you don't know that. Is that what you're looking for?
No, I'm talking about more claims data, timely reaction to the patient population that they are aware of as it relates to, did they have an A1C? Are they scheduled or due for their colonoscopy? Have they had their breast cancer screening?
From services outside of your network, rather than, I mean, you know what's going on, and your PCP knows what he or she is driving in your system, but you don't know what may be happening outside your system.
No, I would argue that we actually look at both. So both is going to be critically important. If a patient, I'll just use myself as an example. If I did a colonoscopy in a patient, if I have Susie Smith as my patient, I may or may not be every day aware whether or not I recall doing a colonoscopy on Susie 7 months prior or not. And we get towards the end of the attribution year where we start getting our not met reports for various quality measures. I'm going to want to know that. I'm not going to necessarily know specifically about an individual patient.
I thought my chart would generate that for you.
For me personally?
No. Well, sure,
I mean,
you as a patient, but also, for the person who's attentive, logging into my chart, but also for the physician or the system.
Critical component of that for us right now is we don't have everybody on my chart. We're not all on one unified EHR right now. So, but we're moving there. So October, CSM will be, and obviously next year, St. E. So that brings up a really good point in terms of some of the challenges for health systems that are not on a unified EHR. One of the big investments we're making is understanding the importance of being able to have one standard set of data. We don't have that right now.
Even in Wisconsin?
Even in Wisconsin.
Yeah, let me add one more piece that goes into it, because it really does come back to the role of Centivo. We have said we need to enable some of this best behavior. We frankly need to help doctors be the best doctors. And if they improve their performance for us as a payer and for every other payer, that's great. So as we looked at creating the structure, we said, let's change the payment process to move away from a pure transactional fee-for-service world into things like patient management fees and into incentive fees, and create the upside for the PCPs who are performing well to receive additional compensation and the systems to receive additional compensation on their behalf that enables them to do these things and to make the right kind of investments. And if we've got the right system within the BHCG Centivo world, it's an opportunity for Ascension and others to obviously continue to expand their membership with us, but frankly to take those same kind of approaches and move them holistically across all the patients they serve. So we're really trying to start with the right building blocks to make them as good as they can be, and working back and forth. The contracting pieces work with that, and to the extent that leverages into an improvement in healthcare, no matter who the payer is, we've succeeded.
So 2 quick comments, Dave. Two key pieces to this, as Greg was saying. It's upfront, the doctors know who their patients are. They're not assigned to them after the fact. That's key. And all of the metrics are the metrics that primary care can control. It used to frustrate our primary care doctors to no end when they would get metrics that, that they couldn't control. So it's all metrics that they can control. And I think the primary care doctors are very receptive to it because they know who their patients are, and they're metrics that are well accepted and that they control. That's key to this program.
And let me make one quick final comment on this whole issue of frankly helping improve practice, because it came out of the pharmacy side. And Ashok talked about the Navitas partnership between BHCG and Centivo. And it's not that we expect every employer to come and say, yes, I'm coming into Navitas immediately. But as we grow that book, Navitas has committed to working with people like Greg in the community to really improve prescribing patterns right at the point of prescription, to look at opportunities to change and to really create a change in the world. We've all gone to the pharmacy and tried to have our script filled, and the pharmacist said, "Did you really mean to get that? Because that costs $500. And I now had to go back and circle back to my physician and say, oh yeah, well, this one's just as good and it's 25 bucks. If we can work with the physician community, with the physician leadership, people like Greg, to really change at the point of prescription and to never have that experience again, it's a real win. And so those kind of things are happening as part of this model. I know we're basically out of time with this panel. Is there one last question that somebody wants to ask?
Hi, can you talk a little bit about the challenges of mental health care provider capacity, especially coming out of the pandemic, and what Centivo and the provider community can do to create more capacity?
Yeah, that's a tough one. One of the things that I think many health systems, and certainly we're doing right now, is much like in the primary care workforce, is expanding those that have the competency to provide behavioral health and mental health services as well. The answer is not going to be, as I was joking early on, hire 1,500 more behavioral health specialists, because that's an unrealistic expectation. The pipeline's not that big. But being able to maximize and utilize our licensed social workers, obviously our psychologists, clinical psychologists, beyond the traditional psychiatrist in the behavioral health space is going to be critically, critically important. I don't think that's unique, frankly, to Ascension. I think every health system in the country is probably going down that path right now. So that's a tough one. Behavioral health is really, really challenging in terms of workforce management.
So, yeah, of course, it's across the board nationwide. Some cities or communities are worse than others. I mean, some places it's just tremendously difficult. So without getting into all the virtual care solutions, some may work, some not work, but there are some interesting virtual care things in behavioral health. If you have a shortage of clinical providers, that you may be able to integrate that into the team, not divorced, but like we were talking to some providers in one market to say, here's a good virtual healthcare solution. There really are a dearth of providers here. Can we put that in as a solution? So that I think is an area where I've seen some pretty interesting, innovative ideas that may help. May not solve it, but may help.
Thanks. I could listen to these guys all day, but unfortunately, from a time standpoint, I'm going to let them go. So Greg, Wayne, thanks for the participation.